and thank you for joining us for today's Grand Rounds lecture. It's a great pleasure and honor to introduce today a very dear friend of mine and a very distinguished lecturer and visitor of Kekesh in Saudi Arabia. This is her second visit to the hospital and to Saudi, and we are quite privileged to have her. Dr. Caroline Harper is the Chief Executive Officer of Sightsavers, a not-for-profit UK-based organization, and it's one of the leading, if not the leading organization in prevention of blindness globally. Dr. Harper joined Sightsavers in 2005, where she moved from the gas industry into the not-for-profit sector out of her own interest, inspired by her many travels around the globe and seeing how much need there is for programs that prevent blindness and promote eye health. She also had several of her family members who were visually impaired or had some form of visual disability that had her personally get interested in the field. Sightsavers is one of the leading players in prevention of blindness and disability field globally. It works with disabled people's organizations and with other NGOs and government entities and donors to promote the improvement of eye health and decrease the rate of visual impairment and blindness. Dr. Harper is also a trustee and a board member of the International Agency for the Prevention of Blindness. She has a PhD in energy studies from the University of Cambridge and was awarded an OBE Order of the British Empire for services to the gas industry in 2000. She also received an honorary doctorate in science from the University of Bristol in 2013, as well as CBE Commander of the Order of the British Empire for services to the visually impaired people in 2015. Under her leadership, Sightsavers has expanded significantly, treating millions of people and advocating for policy reforms in the world. Caroline is going to talk to us today about prevention of blindness in low and middle income countries, and she will talk about the role of ophthalmologists and NGOs working in partnership. Caroline.
Thank you very much, Aziz. It's a pleasure to be back talking to you again so soon. Yes, as Aziz has said, I'm going to talk about prevention of blindness and indeed promotion of eye health across low and middle income countries, which is where Sightsavers works, and talk a lot, I think, about ophthalmologists and indeed optometrists and allied health workers and the real importance and problems we have with the lack of health workers, and it's one of the reasons why we do have so much blindness across the world. Now, looking at how many people there are in the world, there's been a lot of work recently been done, particularly by a group of international ophthalmologists and optometrists called VLEG, the Vision Loss Expert Group. I'm not sure if any of you are members of this, but they've been providing information to the global burden of disease group on vision impairment and indeed to the WHO. And these are the numbers, and they're constantly updated. And these are the numbers that the WHO's recent reports, the World Report on Vision, and then following on the Lancet Commission on Eye Health, have been using for their analysis. And you can see, it's affecting 1.1 billion people across the whole world. It's a significant issue. The current estimate of 43 million people actually blind. And then much bigger figures when you get into sort of medium and severe visual impairments. And very large numbers of people considered to be mildly visually impaired, and 500 million who have presbyopia and need reading glasses. So very large numbers of people involved. And I mean, the main causes, certainly in low and middle income countries, of blindness is still cataract. A very straightforward operation, very low cost, and yet that still is the leading cause of blindness across those countries. And then uncorrected refractive error is the biggest cause of vision loss, which can obviously be corrected, but it's huge numbers of people that, just for the want of a pair of glasses, are unable to function as well as they could do. 90% of these 1.1 billion people live in low and middle income countries, and it affects women more than it affects men. And an estimate was done of what is the productivity loss, so what's the impact on economies of this problem, and it was estimated in US dollars equivalent, based on 2018 dollars, about $411 billion is lost to the world economy because of this vision impairment. So we've been trying to argue, as have many others, that governments should look on this not just as a health problem, but as an economic imperative. And certainly many of these interventions, cataract is regarded as one of the most cost-effective surgical interventions that there is. So it is very frustrating actually to see eye health not being given a priority. And we've certainly seen through COVID that, if anything, we've taken a backward step, and eye health has gone down the priority list for many countries. So as I mentioned, cataract remains the single biggest cause of blindness across the world. And this is a graph that was done by the VLEG group. This one's led by my friend and Aziz's friend, Serge Reznikov. And what it shows you up the y-axis is the cataract surgical rate in these different regions, plotted against the prevalence of cataract blindness. And unsurprisingly, the higher the income, the higher the CSR, and the lower the amount of cataract blindness. The size of the circle represents the populations within those groups. But there are some slightly odd things in here to be seen. I mean, first of all, the highest area for prevalence of blindness is South Asia. So India, Pakistan, Bangladesh. And I was surprised about that personally. I'd assumed sub-Saharan Africa would be further along that right axis. And then you see your region is quite interesting, North Africa and Middle East, not as bad, but very low, relatively low surgical, cataract surgical rate. And there are some interesting anomalies in there which I'll come back to. And if we look in a little bit more detail, if you look at the CSRs in those different regions, you can see, I mean, the first thing that strikes you is how low the cataract surgical rate is in sub-Saharan Africa, particularly if you were to compare that with high income, so, the US, Europe and so forth. Very, very significant difference. South Asia, which I mentioned as having the most significant problems with cataract blindness, does actually have a reasonably high CSR. So that I find is quite interesting. Hopefully that means, therefore, that they are going to be catching up because they have the furthest to go. But what I find odd, though, North Africa and the Middle East, it's not great, but it's not actually bad. And when you look, here's something that I find odd. So there are 10 ophthalmologists per million people in South Asia and 43 in North Africa and the Middle East. And yet if we go back, look at the CSRs. Why is it that far more ophthalmologists in North Africa and Middle East are doing far fewer cataract surgeries? We think that some of that is because a lot of the ophthalmologists, particularly in North Africa, aren't actually doing surgeries. Many of them are actually focusing on refractive error, and it's also a way of boosting their income. But it's certainly an issue. Whereas South Asia, you are seeing that these fewer ophthalmologists per million are actually performing a higher rate of cataracts. We think there may also be some issues that they're getting in and performing cataracts a bit earlier than in some places, but I think a lot of analysis is still required to understand some of these figures. And the really stark number, of course, here is sub-Saharan Africa. Just 2 ophthalmologists per million people in sub-Saharan Africa, compared to here, to Europe or US, where it's more like 80. I didn't actually check how many you have in Saudi, but it's an awful lot more than 2, you could be sure. I suspect it's closer to 80. So, I mean, this is what we're really grappling with in trying to tackle blindness issues. Now, one of the big changes that's happened over the last decade or so is starting to think about eye health as part of the overall health system. When I first came, we tended to see eyes as a very separate thing. And we would, yes, there would be eye care plans written in countries, but they would be kept separate. They wouldn't be integrated into the overall health plan. Now that used to cause problems. I mean, I remember Nigeria in particular, where they managed to get funding from the World Bank for their national health plan, but because the eye plan was something separate off to the side, it didn't receive any of the funding. Similarly, they had an eye health workforce plan that wasn't part of the overall health workforce plan, and the Ministry of Health therefore didn't prioritise it. So one of the key things that we've all been trying to do is get eye health to be seen as part of the overall health system and not a speciality so far out on its own that it's regarded as something separate. Now this is a WHO model of universal health coverage and seeing what would need to be done with eye health if we were to achieve universal eye health coverage. And there are sort of essentially three axes. The first one to look at is the vertical axis of the cube. This is where you're looking at funding and what proportion of the eye health service costs are actually covered from pooled funds, so either from the government funding those services or from health insurance providing those services, and the remainder would be paid for as a user fee by the patient. And to enable universal eye health coverage, you want to get as close to the top as you can of those kind of pooled funding, rather than having the burden fall on the individual patients all the time. Second one, if you look along the bottom, the proportion of the population, so the problem we often have is eye health services are only available to a portion of the population. And in particular, in low-income countries, it's always the urban population. So the health facilities are all concentrated in the urban centres, and frankly, such ophthalmologists as there are will always be in the capital cities. And so trying to reach anybody who can't access those places is really difficult. So to get universal eye health coverage, we need to try and extend that proportion covered to 100%. And then finally, the remaining axis is looking at what proportion of the required eye health services are actually available. So when you have an eye health service, does it actually provide all the things that you need, or is it really only providing a small portion? So this is what the WHO is looking at, and it's trying to encourage people to think about eye health as part of the overall health system. Now when they produced the World Report on Vision, which was a couple of years ago, and sadly I think its promotion was impacted by COVID, because we were going to be having a whole series of launches of the World Report on Vision in a various number of countries. And that, I'm afraid, did suffer from the fact that we couldn't do it during COVID. But these are some of the key principles. And I think just to take one step back, the role of the WHO here has been seminal. And before they produced this first World Report on Vision, there have been a series of resolutions passed at the World Health Assembly on eye health and on the prevention of blindness. And one of the things I think you in this room can be proud of is that two of the ones that were really critical in the mid-2000s, Saudi Arabia was one of the key proponents of this, was leading the charge and speaking up and promoting this. So actually this country has a lot to be proud of in its leadership in this area. And now, these are the things that the WHO are saying are essential for global approaches and strategies. So organisations like ours need to take this on board. So the first is thinking about delivery of integrated, people-centred eye care. Integrated means integrating with the overall health system, but actually going beyond that. And so looking at integration within the education system, and in certain purposes integration with water and sanitation systems. So it's actually looking at the whole provision of infrastructure and so forth in the government, in the country, and again not seeing eye health as something on the side. And people-centred eye care, and that's a very similar concept to many facets of medicine, when we're trying to focus on the patient as an individual and ensuring that they are consulted and they actually receive the treatment that they need. So I think that's not just specific to eye care. Then strengthening the eye health workforce. I mentioned before to you at the beginning, one of the really serious problems we have is a lack of ophthalmologists. And if I were to show you those numbers for optometrists, it would be even worse. In some countries in sub-Saharan Africa, there are none, or maybe one in the whole country. It's just a cadre that's barely there. And then, of course, we need also a whole range of ophthalmic nurses and orthoptists and technicians, and this whole workforce area is one, I think, which is really holding back, particularly sub-Saharan Africa. Then improving the quality of care. I mean, this is an area, I have travelled over the 17 years I've been here over to a number of different countries. I've seen all sorts of different hospitals. Obviously I saw this hospital yesterday, which has to be the pinnacle. But then I've seen hospitals in rural areas that are over 100 years old. Examples like coming around a corner to see a whole load of gloves drying in the sun that had been rinsed out after one operation before being used for the next. These sorts of situations. I remember walking through an operating theatre that was used for cataract operations and several other things as well, as the builder's dust was gently drifting through the air onto the patient. So, there are some really serious problems. Equipment, so sometimes you will have quite nice shiny equipment, maybe some donor has given that piece of equipment, but nobody knows how to maintain it, so the minute something goes wrong with it, it just sits there. Or I've even seen situations where shiny microscopes in a box in a cupboard, it was donated 3 or 4 years earlier, but nobody knows how to set it up, so they've stuck it in a cupboard. So these are the sorts of situations that you have. We have to ensure quality of care, and not least to ensure that the patients have the confidence to go to those hospitals to receive care. Because if the quality is poor, they're just not going to go back. And they're going to tell all their friends and relations, you shouldn't go to that hospital. Next is improving equity. And this comes to the heart of the universal eye health concept and indeed the Sustainable Development Goals. Trying to reach everybody, not just the privileged few or indeed the few who can afford it or who live in an urban area, but reaching everybody, reaching men and women. There are a number of countries where we work where you see a much higher proportion of men than women coming. We've done a number of things there to try and ameliorate that. So I think one of our best examples is in Pakistan, where you have a concept called the lady health workers. These are community health workers, they're all women, and they go into the far reaches, into people's homes, where a lot of women won't actually leave their houses, and they are trained to identify common eye complaints and then try and refer them and potentially accompany them to the hospital if need be. So we're doing our best, but we still have issues around gender. And then we have enormous issues around disability. Are people with disabilities able to access eye care? Now this is something Sightsavers I think, frankly, neglected for many years. When we were looking at disability inclusion, we focused either on specific disability programs or on things like are our offices accessible or are we employing disabled people. But we forgot to ask the key question about are the programs we are supporting inclusive? Can a person using a wheelchair actually get into a hospital, for example? And so now we're looking much more at ensuring equity and measuring whether we are ensuring equity. And then finally, in innovation and research, I mean, everyone says this, but it's absolutely fundamental. Can we find new ways of doing things? And the sort of research that we're doing, which I'll talk a bit more about in a moment, it's not medical research, it's research about operations and how to do things better. So, just a little bit to explain who we are, Sightsavers is. We're not for profit, we are a registered charity in the UK, that's our legal status. We've been going a very long time. We were set up in 1950. Our first name was the British Empire Society for the Blind. That's not an acceptable brand name in today's world, as you can imagine. And we changed our name to the Royal Commonwealth Society for the Blind not long after we were set up. That is still the official title of our organisation. And it's one I tend to use a bit, say, in this Platinum Jubilee year. but we're known as Sightsavers, and that's our brand. And we were actually set up by a man who lost his sight at the age of 12 in an accident at school. And he went travelling with his wife, Jean Wilson, to what were then called the colonies, looking at what the situation was like for blind people, and set up a whole load of blind organisations for blind people, and then started doing research and gradually got into prevention of blindness. His widow is still a vice president of Sightsavers, and she's 100 years old in August, and she's still very feisty and very involved. To give you a sense of the size of the organisation, last year, which was the biggest year for income, our turnover was £124 million in cash. And then we also received drugs donated by pharmaceutical companies. The value of those was another 100 million plus. These are drugs that we distribute for neglected tropical diseases. So in total, our turnover appears as over £220 million. So substantial organisation. And although we are officially registered in the UK and we have a lot of staff there, we work in 32 countries across the world. We have 730 staff, and around 2/3 of them are based in the countries where we work and are nationals of the countries where we work. We don't send volunteer ophthalmologists from the north to the south. We aren't somebody who goes in, helps to do a lot of operations or distribute a lot of glasses and then leaves. That model has passed its time, in my view, because yes, you're doing good, yes, a number of people will get to see again, but you're not making any systemic change. This is not a long-term solution. And indeed, it can have unintended consequences in the short term. We've seen situations where government hospitals deteriorate because visitors come and set up in a local community place and they do operations, and the people think, well, I'll wait until they'll come back because it'll be free. And also, they disappear before they've done all the follow-up. So you may well have cataract operations done and not done well, off go the volunteers, and then the burden falls on the local hospital to try and clear up the cases that were not done well. So we don't do that. In fact, we never really have. So this shows you where we work, and you can see a real preponderance for sub-Saharan Africa. That is our heart. But we also work in the Emre region, Sudan and South Sudan. We have done some work. It's not a heart at the moment. And we are doing some trachoma work in Egypt, which I'm very glad about, because as you saw if you were at my last lecture, Egypt is one of the places where trachoma is registered most historically. And we've also done some trachoma work in Yemen, working with a local partner. And then we do work in India, Bangladesh and Pakistan. Originally it was Commonwealth, but as you can see now, we cover a lot of Francophone Africa, Lusophone Africa and parts of North Africa. Now somebody asked me earlier in a previous lecture, how do we think about our strategy? Well, first of all, it starts with the vision. And the vision is very simple, and it's been that way for a long time. So we are looking and fighting for a world where nobody is blind from an avoidable cause, and where somebody who has a disability can participate equally in society. So we look at the whole sort of range, if you like, from prevention of blindness through treatment, including, as part of that prevention, behavioural change, and then where we are unable to support treatment where a person is going to be blind, we will then support people with disabilities, and we actually look at support for a range of disabilities, not just blindness. And in our programmatic approach, as I said, we're not volunteers. We don't directly go in and implement. I don't have a big team of ophthalmologists. But our idea is to develop and demonstrate ideas and approaches that work so that governments, who are the duty bearers for health, and other stakeholders, so many countries, NGOs, local NGOs are an important part of the health system. So for example, in India, you have a lot of very good NGO hospitals. But the idea is so that those local actors can take on those models, those approaches, and take them to scale. And we as Sightsavers need to be very careful not to become the eye health system in a country, and we've made that mistake in the past. So for example, in the Gambia, we did a lot of very good work, and we really put a lot of effort and resource and some great people in there, dramatically reduced the blindness rates there, the prevalence rates. It was tremendous. And so we went to the Gambian government and we said, it's really good news, now we can leave, you've got what you need, and we can go and prioritise somewhere else. And they said, but the whole thing will fall over if Sightsavers goes. And we realised that it wasn't actually the Gambian eye health service, it was the Sightsavers eye health service. And we've learned that we can't do that in the future. We need to make sure that what we're doing is building up the local capacity so that in time they're able to run on their own and they don't need to lean on an NGO indefinitely. So this is, if you like, the implementation part of our triangle. We then try very hard to design all our programs around evidence. So the research that we do is all to gather evidence about what type of programs we should run, where and how we can make them better. Like I said, we don't do medical research. And then what we try and do is take that evidence and put it into our programs. You know, I have seen in the past where loads of research is done, so often academics will do brilliant research and it will sit on the shelf and it will never change anything. So we're trying to make sure that we learn and improve our programs and disseminate the work that we've done so others can as well. And then the final part of the strategy is the influencing piece, and this needs to take place at the global level, at regional level, and at the country, and indeed at the provincial and local levels. Because as you can see, if we're talking about disseminating ideas and approaches, you have to persuade people to do those. So we've spent a lot of time helping governments, working with local NGO partners to make sure the plans and strategies are appropriate. And you'll see a little bit later on, I'll give you a few examples of that. But right down to a fairly sort of local level where we sometimes will advocate for somebody to be for them to post an ophthalmologist to a particular area where we can see there's a shortage. And then at the centre, we have 5 thematic strategies that guide our work. We've just refreshed all of these, and I'll tell you a little bit more about them in a minute. And then obviously you need to monitor what you're doing, and we have something called a SIM card, Strategy Implementation and Monitoring Card. Some of you may know the balanced scorecard approach. It's used in the corporate world, and this is how we take our KPIs and manage them. And I'll show you that at the end. So we have a program strategy. This is an overarching strategy for all of our work on health and inclusion. And there are 9 principles that we use that underpin everything that we do. The first, leave no one behind, the equity principle, which is taken directly from the Sustainable Development Goals. And this is driving our push for equity. And I mean, I remember there have been times when we thought that we were reaching the people that we wanted to, but found in reality we weren't. I'll not forget one experience in a francophone country when they take the CEO up to visit and you meet some of the patients, and we tend to ask, oh, hello, and how does it feel? And what difference has it made to your life? And what do you do? I'm expecting to hear this woman is a subsistence farmer, or she might have some labouring job, and she says, oh yes, I'm a lecturer in French at the local university. Yes, your woman's entitled to eye health care, but it wasn't something that I expected us as an NGO trying to reach the poorest of people to be serving. And when we did some research in that area, expecting to be reaching sort of the lower quintiles of income, we discovered that we weren't. We were reaching people in the middle. So we still have work to do to try and actually reach the very poorest people, the most marginalised ones. Then we have coherence. This is trying to bring our strategies together. We used to have eye health over here and refractive error, so we'd have the ophthalmological approach and the optometrist separately. We'd have a separate education approach and social inclusion, and they didn't talk to each other and they didn't think about each other. And now we're trying to make sure that all of our strategies dovetail and our programs consider all those aspects. As you'd expect, sustainability is in there, and that's not just financial sustainability. It's also thinking about, have you embedded your programs within the local community? It's thinking now about environmental issues as well. Then the system strengthening. I mentioned to you before how sometimes inadvertently you can damage a system. And I've seen other NGOs in good faith build a hospital not very far away from a government hospital, and it can be a fabulous hospital, but then all that happens is all the doctors that were working in the government hospital move across into the NGO hospital, and the government hospital fades. So you need to be thinking, what are we doing to strengthen that system? And you need to think about the various aspects as well. So when you look at the different building blocks of a health system, we look at, can we help that government, say, with its health data management? So it's not just about the straightforward service delivery. Quality, I think I've mentioned, and I'll come back to again in a minute. And then being evidence-based. We used to make decisions by, well, this is what I believe. And a lot of our people had been in their jobs for a long time, and they would say, well, I know what works. I've got experience of what works. And sometimes that's okay. But when you do research, sometimes you find what you thought worked, and thought worked for 10 years, actually isn't working. And one of the really hard things to do then is to stop it. Because sometimes these are people's pet projects, and they put their lives into them. They have a partner perhaps that they've been working with a long time, but it's just not right. And we did a big exercise about 8 years ago where we realigned our whole program portfolio. We closed down a third of our projects. That was very painful. But it did mean now that all our projects, we're confident, are aligned with our strategy, and that's important. Then partnership and participation. When I'm talking about partners here, it's partners in a country that we're working with. Often it's the Ministry of Health, but it can be NGOs, and it's very important that we do that. And participation is about trying to get the patients, the communities, involved in some of the decision making. Now that is very difficult, because how far along that route do you go? But trying to do more of that is seen as very important in development. Then alliances, these are with other NGOs, international NGOs, big hospitals, but potentially KKESH, and it's working with others who are trying to achieve the same as you. And finally, safeguarding, which is an absolutely crucial one, particularly now there have been a number of exposures of NGOs where their staff or their partner staff have been, whether it's fraud or whether it's abuse, bullying, all kinds of things. And of course, within this context, the medical context, we have to make sure we have good standards of clinical governance. And as you heard when I talked about the drying of the gloves, that's not always been the case. So, to summarise how we work, I'm not sure how familiar you all are with NGOs, but I know when I came in, I always assumed NGOs sent armies of staff out into the field to do stuff. And that's not really the case. So whilst we will have quite substantial offices in most of these countries, what we're doing is working in partnership with the ministries. In every country where we work, we'll work with the Ministry of Health. If you don't do that, you'll never be accepted as part of the overall system. And it's not always easy. Ministers of Health come and go, so you're constantly rebuilding relationships, and that also happens too with the key civil servants. And when you work with the ministries, you have to work at the next level down in the provinces. Many of the countries we work in have devolved the decision-making power of the ministries down to where it's the province level. Pakistan, for example, had the 18th Amendment, which pushed all of the decision-making power further down. So it's not enough to just work at the federal level. And then a lot of the real decisions will be made even at the district level. So if I visit a country, for example, I will spend at least a day in courtesy calls, meeting all the people at all the different levels, have to show respect, have to recognise their key roles. And we also will work with the Ministries of Education and Social Welfare, part of our disability work. And then we have over 200 local NGOs or civil society organisations that we work with, and all the key INGOs, international NGOs. And then, this is unfortunate nomenclature. The disabled community calls their organisations of persons with disability. Now, to me, this is an outpatients department, but actually, it's not in this case. It's an organisation of persons with disability. We're also members, as Aziz said, of the IAPB, which is an umbrella of all of the people working in eye care, where both Aziz and I are on the board, and Aziz is actually the regional director for this region. Then there are other coalitions. There's one for trachoma control, and there is an EMRO group for that, and there's an international disability group. It's really important for everyone to sort of try and avoid duplication or conflict, because all of us are trying to do the same thing, and sometimes we're in the same countries and we don't always have the same approaches. Very important official relationship with the WHO. So this is a status, it's called official relations. So we work with them as, on an official plan. And then the regional levels too. We have partnerships with Africa and to a lesser extent with EMRO. And again, WHO can be critical and are setting all the standards for what you're trying to do. And then we also have independent research status. This enables us to apply for grants for research work, and it also gives our research more sort of status. So here are the 5 strategies. The eye health, which is pretty much the ophthalmic side of our work. Education, where we're looking at right to inclusive quality education for disabled children. Neglected tropical diseases. There are 2 which cause blindness, trachoma and onchocerciasis. That one's also known as river blindness. And there's also lymphatic filariasis, which is treated with the same drug as onco. And then there's deworming, which we also do. We do all 5 of those diseases, not just the blinding ones. Then, of course, refractive error, which is where the optometrists come in, and it is the biggest cause of visual impairment. And finally, social inclusion in all its aspects to create a more disability-inclusive world. And here are the strategies that we produce. If anybody's interested, you can access them through our website. I no longer travel around the world with piles of paper, so I haven't brought any with me. Now, having talked a lot about the whole kind of health system strengthening aspect, it still remains the case that it's important to look at disease treatment. And as I said to you, cataract is overwhelmingly the biggest cause of blindness, and particularly in low middle income countries. I found it interesting talking to some of you on my trip around here, how certain diseases in certain countries are so prevalent. So a lot of you have talked about keratoconus here. And actually several of my friends at home have keratoconus. And yet this is not something we encounter in Africa. I mean, it's bound to be there, but it just doesn't feature. So you do have different places with different diseases. And cataract is not something that attracts huge amount of interest from donors, which is a shame, but it is something that our mass markets, so our individual donors, do get excited about, because you can show these wonderful stories of people who were blind on a Tuesday and who can see on a Thursday. And you do have some really heart-rending stories. We have a lovely video of an old man and an old woman who've both been blind for the last 20 years. And we operated on both of them just before Valentine's Day and then did a video of the 2 of them. Very risky, of course. They could have taken one look at each other and went, oh, goodness me. Fortunately, they didn't. And then I mentioned uncorrected refractive error. Now, this is one which is perhaps more neglected by the NGO community. Because I think a lot of the push around IAPB historically, and many of the NGOs, has been driven by ophthalmologists. And the optometrists have not really been as a strong a force. And what that's meant is that refractive error has been seen quite often as a sort of second-class thing. It's just a pair of glasses. But of course it's way more than that. Not only is it the biggest cause of visual impairment, but most people who have a cataract will probably need a pair of glasses. So, and this has a huge impact on people's education. So that's the second very important one for us. Then if you look at trachoma and onco, these are not significant in terms of size anymore in comparison with cataract, but we are on an elimination path for these diseases. So my goal, our goal, is to try and reach a point where trachoma is eliminated. In other words, it's driven to such a low level as not to be of any consequence in terms of public health. And that status has been achieved by a number of countries. And in sub-Saharan Africa, you see Morocco, Gambia, Ghana, Togo just declared trachoma free, and this is validated by the WHO. That was just last week. I think Oman has in this region. And it's something, it's our ambition to be able to say that that's across the world, certainly by 2030. Onchocerciasis, that is also one you can eliminate, but it takes a very long time. That's a distribution of mectizan, and you have to do that for 20 years. I don't know how many of you will be familiar with onchocerciasis. It's not in this region, so you may never see a case of it. But the fly bites is a maximilian fly that lives in fast-flowing rivers. It lays an egg in you, and perhaps it will work. And then that worm breathes. And the microfilariae travel through the skin. As they travel, it causes intense itching, and then they come and they destroy your eyes. And when another fly bites you, it takes the microfilariae to somebody else and infects them. So we have got this treatment, Vectisam, donated by Merck, which is contraceptive for the worm, so it no longer produces microfilariae. But we haven't yet got a macrofilariae that kills the worm. So we're still on a very long period of doing that. Now we are increasingly involving ourselves in glaucoma and diabetic retinopathy because these two diseases, whilst less prevalent than the others in the country where we work, are certainly coming up. Glaucoma, particularly in West Africa, is a problem, and of course in India. And then diabetic retinopathy is surging in, particularly in Asia. So we can't just ignore these at all now. Where we're working on cataract or URE, we are also now increasingly working in these two diseases. So just to give you a sense of scale, in terms of service delivery, last year, and remember 2021, we were still impacted by COVID, particularly in Q2 of last year, where in India, many of the hospitals were shut in because they were having the Delta wave. But we supported about 367,000 cataract surgeries. I'm hoping that 2022 will reach close to 500,000. And 585,000 pairs of spectacles. And then one that I'm particularly proud of, so this is just last year alone, 170 million treatments for neglected tropical diseases. That's a very large number of tablets distributed across Africa. And then training is hugely important, so supporting training of about 125,000 professionals on shorter courses, and then community volunteers. This is very important for the neglected tropical disease work, where it's community volunteers who actually distribute the tablets. It's not all health professionals. And to give you an example of one of our programs, this is actually probably an example of where a CEO makes a decision based on emotion and not on data. But it turned out to be a good decision nonetheless. So I was traveling in Mozambique about just over 10 years ago. This picture on the top is a general hospital in Nampula, which is in northern Mozambique, supporting an area. It's a tertiary hospital that supports about 7 million people all around. And they were operating in a general operating theatre. This is the one where I described about the brick dust just floating down. And while I was there, I met this little boy. We don't really know what had been wrong with him. It was some form of eye cancer probably. But he was, one side of his face was stunningly beautiful, little 5-year-old, and the other half was gone. It had just been completely eaten away. And his parents had brought him to this hospital. Of course, it was far too late. They'd taken him originally to traditional healers and tried herbs and all sorts of things. And you know, he almost certainly died within the next month or so. But I looked at the facilities and the huge queues. I mean, it couldn't be more of a contrast to your hospital here. You know, there were people sitting on the floor with quite horrendous conditions. Big tumours, you know, horrible traumas, all kinds of things. And very few staff, massively overworked, filthy hospital. And I just said, well, this is untenable, this is awful. And I just said, we're going to build an eye unit here. And we funded an eye unit, so the picture down at the bottom is the eye unit in Nampula. So it definitely looks a little bit different from the one on the top. And so this was about 10 years ago that we built it. We've supported it ever since. We've been training personnel, so ophthalmologists and also ophthalmic technicians. We're actually doing outreach now to the other districts in Nampula. We're doing operations, the ophthalmologists are doing operations in other hospitals in the area, the sort of secondary hospitals. And we've managed over the last period, so we did some blindness surveys, one in 2011 and one in 2018, and you'll see we reduced blindness in the over 50s from 6.2% to 3.9%. So, you know, that's a good result. Cataract coverage is still quite poor, so it was only 10% in 2011, 31% of people who need cataracts getting them in 2018, so there's a way to go, but it's still a very good result. So this is one of our flagship projects, and it's been funded by a lot of major donors who've become quite emotionally involved with it over time. The second example, this is in refractive error. We do a lot of school eye health, and we call it school health integrated programming, because we don't often do just pure vision screening. We try and integrate that where we can with existing school health programs. And a lot of countries do deworming of their children. And we've paired up the vision screening with deworming. And actually we're getting funding from Dubai Cares to do this, and also to do some of the deworming. And then you train the teachers, and the teachers learn how to do very simple screening. Has the child got an eye problem or not an eye problem? That's all. They're not diagnosing what the problem is. Because then once you've done the initial screening, there'll be a mobile team of optometrists who'll come to that school, and they will do the refraction, and they will work out what the diagnosis is. They will also refer any child who has more than just simple refractive error. And then we will take bespoke spectacles, or indeed ready-mades, to those schools for those children free of charge. So you're not in a situation where the parents have to take the child to the optometrist in the town. We've done a lot of work on standard guidelines for vision screening. This is in partnership with other NGOs who work in this field as well. We got some World Bank funding in the early days to do this in a number of countries, in Cambodia, Ethiopia, Ghana and Senegal. And we've scaled this now, so Liberia, Nigeria, Pakistan, which is one we're really expanding in, Tanzania, Mozambique and India. So this is something where we think it's really important. You catch the child who can't see, their education prospects, their life prospects are changed, and it's very, very low cost. So, I mentioned earlier that whole problem about not enough ophthalmologists, not enough healthcare professionals. And certainly if you look at WHO, their global atlas will tell you that the critical shortage of health workers is probably the most significant problem that we face. So we're taking a twin track approach here, investing in the eye health workforce directly. So that's which districts we're working in. We will support individual ophthalmologists or allied health workers. We will fund them to be trained, to get qualifications where we're working directly. But we also work with the regional and national partners in initiatives which will scale that up. So that's promoting policies and strategies and supporting training institutions and helping them to develop proper curricula. So there's, as I said, a twin track approach. I won't go into details here. You can just see the sort of numbers that we've got. And then we have a key relationship with the College of Ophthalmology in Eastern, Central and Southern Africa, where we've been helping them develop accreditation standards and mapping where you have the health workers and where you don't. Now, there are some interesting controversies, I think, in some of these areas. One where there isn't actually, I think, a solved resolution, which is the whole area of task shifting and who can do a cataract operation. So in a number of countries, we've trained ophthalmic nurses to do cataract operations. They're cataract surgeons. And that has been very successful in some places. Others are very unhappy about that because, really, is it acceptable for a nurse to do an operation that's that invasive? One of the big advantages is that the ophthalmologist will spend a lot of time, or they'll want to live in the urban centres, and they often want to work in private practice. When we're training up ophthalmic nurses, they're much more willing to work in those rural areas, and therefore you can reach those patients otherwise not reached. I have sat in some interesting meetings where the doctors and the nurses are having big arguments with each other over whether they should or shouldn't be able to do it. So that has been quite fun. And we have a program in India, which is a fellowship program amongst ophthalmologists, where we're taking young ophthalmologists and they're given a program of 2 years where they're given access to senior ophthalmologists in major hospitals and real state-of-the-art mentoring. But the deal is that they will then go and stay in, say, Bihar or Orissa, one of the places that people don't want to work, so that they can bring cataract operations and services to that area. This was a little bit damaged by COVID, but we're restarting it up again now, and there's been over 5,500 cataract surgeries done by those fellows to date. This one, I won't get into too much detail. This is actually the Maghrabi Hospital in Cameroon, and this is looking at new ways of financing. It's something called a development impact bond, Those of you who follow the development press, these are very trendy at the moment, but they're very difficult. So what we had here is a loan of $2 million, and then over the period of time, there's a performance-based financing based on the number of quality cataracts that you're doing. And those fees from those cataracts will pay back the loan. And it's a big partnership with Mugabe, with the Conrad Hilton Foundation, Fred Hollows and others. So my take on this is it's an interesting way of accessing funding up front, but it's expensive, it's complicated, and then if you have big things happen like COVID, which can impact on your performance, it can be difficult. So I'm not entirely sold on development impact bonds, but they are one way of dealing with things. So looking at, we've talked about cataracts and refractive error. If you look at Onco, we've supported now over 600 million treatments, and if you look at that graph, you can see COVID in the middle there. Substantial numbers, but we are now reaching a point where we can stop in some places because we've been going so long. Parts of Nigeria, we've been able to stop treating and the people are still protected. So we are breaking transmission. And we're doing some really interesting work looking at the monitoring of the flies in some cross-border areas. And this is actually being funded by the Crown Prince's Court from the UAE. Trachoma, I mentioned to you, very, very important. 183 million treatments there, and we again are stopping treatments in a number of countries and reaching elimination. And there's a really interesting project going on in Nigeria because we discovered that azithromycin, actually reduces infant mortality. And so we have reduced, normally you only give to children down to about 6 months. Now we've extended that down to 1 month. And we're doing research to see what that impact that's having on child mortality. And then on surgeries, you can see about 500,000. And again, we're reaching a point where we're not having to do TT surgeries for the population anymore because trachoma nearly there. Quality, I won't go because I can see that we're running out of time, but we have a very comprehensive quality standards. This is so important, covering all these aspects, service delivery and patient safety and so forth. And then in eye health research, we're looking at surveys about where's the problems. We're also looking at equity and sustainability, the task shifting that I mentioned, and how to reach the hard-to-reach people. And the thing I'd like to leave you with in terms of findings, you probably saw from the beginning, we are making great progress in South Asia. India and Pakistan are making fast progress, and Pakistan, I believe, will be about to announce some really good news on their blindness stats in the coming months. But Africa's not going forwards. We just did a recent survey in Sierra Leone, and although the proportion is the same at 5%, the absolute numbers has increased by 64% because the population is aging, and we are not keeping up. We're not running fast enough, and it's worse for women than for men. So there's a lot of work that needs to be done. And quite a lot of it is in advocacy, so here are some examples of the various things that Sightsavers is doing to try and influence governments to prioritise eye health in the various countries. This is our monitoring card. I'm not going to tell you anything about it other than you can see it has different objectives, and it has red, amber and green on various indicators, and we monitor this regularly to see how we're doing. So this is a film from the 1950s that just shows you how things have changed.
The Royal Commonwealth Society for the Blind carried out a survey of blindness in West Africa. The task was to arrive at the number of blind in northern Ghana and northern Nigeria, and to find ways of reducing the amount of blinding diseases in those countries. The survey cost £48,000 and was carried out by Dr. Roger, an ophthalmic surgeon, who spent 18 months in Ghana and 2.5 years in Nigeria, and the late Dr. Chris, an entomologist, who was over 2 years in northern Ghana. Dr. Chris was to study the fly which spreads river blindness by examining freshly caught flies under the microscope. Dr. Roger examined 7,000 men and women and 1,300 children of a bewildering variety of tribes and languages. During the whole of the survey, visits were made to small towns and villages wherever the population was most dense, interspersing it with visits to some of the more inaccessible and sparsely populated areas, selected generally from the map. During these journeys, one Land Rover had its springs wrenched off, and on another occasion, the frame of a car was buckled and Dr. Roger thrown violently out. Here Dr. Roger is arriving at a village on the plateau of northern Nigeria, and the first thing we see him doing is to gain the confidence of the chief or village headman and arrange where the blind should assemble. The team is a small unit which can set up within tents a complete eye clinic with sterile trays, inspection lamp, ophthalmoscope, and a biomicroscope. This unit could also set up a theatre for major operations. The commonest causes of blindness were trachoma, a contagious disease, seeing eye cataract, and especially in Ghana, Onchocerciasis. In the areas where this rare blindness is found, snips of skin were taken from patients. It is by examination of these that the disease can be identified. Blood samples were also examined. We will now see the work which Dr. Crisp was doing. This river is dangerous. In it, the fly breeds which causes such widespread blindness among the people of the villages of northern Ghana. Dr. Crisp required great numbers to be caught, which he could examine microscopically, as well as the larvae and pupae, which are here being collected. In this work, Dr. Crisp and his team travelled for over 30,000 miles, much of it on foot or bicycle, to remote depopulated spots. The main task was to discover how the insect survives the dry season, when most rivers cease to flow. Evidence suggested strongly that it was in the adult stage. Trials have shown that it is easiest and cheapest to attack the larval stage, and the simplest way is to treat the river with a solution of DBT in fuel oil or a DBT emulsion. The Royal Commonwealth Society for the Blind hopes that the work of Dr. Rogers and the late Dr. Crisp will enable this human tragedy to be grasped, and that in future there will be many less than 400,000 West African men, women, and children who cannot see this glorious African sunset.
So thank you very much. It's a bit different now, but the problems are still the same.
Thank you very much, Caroline, as usual. Very informative, very interesting, very exciting, and very important points that are worth discussion. I think one of the points that we probably need to discuss, and maybe you can explain a little bit more, is the fact that we're moving away now from ICAMs. There are a lot of NGOs, especially from our region, who are still into that practice. Going into a country where there is a need, setting up a camp, operating for 2 weeks. Some of us, some of the team members here have donated their time and volunteered to be with them. Why do you think these are not sustainable anymore, or should not be done?
I think the problem is, as I said, that it's great that numbers of people get to see. I mean, let's not denigrate the work of those ophthalmologists who go there and who give sight back to people who otherwise would not. But the problem is, it isn't a long-term solution, because the people then in those countries are coming to rely upon these NGOs coming. And what we need is for them to train their own ophthalmologists, for them to provide their own eye health services.
One thing that I always admire are people like the 2 doctors that they mentioned in the video, who left their country, went to a totally strange land, and not to the main cities. They went to the periphery, dedicated years of their life to help others see. There is no financial gain, there is no fame, there is no academic gain, and yet they gave up everything to help fellow humans. I'm not sure how much of that feeling or principle is still within us now, as the profession is moving into being more focused on finances and financial gains and prestige and your position in the community, while the earlier generation were more focused on the essence of medicine, which is helping other people. Now, as a last comment or question, Caroline mentioned the fact that we have cataract surgeon in Africa, and as she very clearly outlined, there is a major problem. There are people going blind. There aren't enough ophthalmologists. So they were forced to find a solution, and training doctors to be ophthalmologists. There aren't many doctors around. The risk is if you train a doctor to be a cataract surgeon, he will then switch into private practice because the demand is so high, and he will move to his own practice or go to another country now that he has the skill. Whereas when you train a nurse, she won't be able to leave because she won't be able to practice except in that facility, theoretically under the supervision of an ophthalmologist. Now, having explained it in that sense, I'm not saying I'm for it or I support it, but just to explain the facts that when you make a decision, there are repercussions. When you say no, surgery is for doctors, there are people who will go blind, and when you say no, it's fine, let it be done by nurses, then the risk theoretically is higher in the hands of those without medical experience or expertise. So how many of you would support the concept of cataract surgeons? Cataract being done by non-medical professionals. Raise your hands. How many are totally against it, out of principle? Okay, I guess the ones against are much more.
Oh, I don't know. I think it's quite evenly balanced, actually.
I don't think so. Okay, how many are for it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. How many against it?
Oh, that's more than there was before.
Thank you all very much. Thank you very much, Caroline. We have a little souvenir before we